Good afternoon. My name is K.Mills, and today I just want to talk about some troubling kind of things that are going on in the nursing field and stuff that I feel needs to be touched on to improve um, the medical field for all, for the hospital, financial aspects, for the patients, and for the nurses as well. So, the biggest topic I want to, or the two biggest topics actually that kind of correlate with each other is nursing burnout and nurse to patient ratios. I think that those have are very much linked, and I think that nurses are asked to do a lot more these days, and hospitals are trying to cut corners to save money financially, which I understand. You know, we want to keep the doors open, we want to keep the lights on, we want to keep providing for the community. So I understand that they have a job as well. But I think that there are some things that are missing, some disconnects that can be looked at to ways instead of cutting back the amount of nurses on staff, cutting back um, resources for nurses, or cutting back hospital staff, I guess you could say, or making nurse to patient ratios higher. For instance, 1 to 5, 1 to 6. You know, I feel like hospitals are trying to save money that way when there's a different way that hospitals um, can save money. So, just a little history about me. I've been an ER tech for about 8 years. I've worked at Banner Gateway and I've worked at Banner Thunderbird in the ER. Both very tough places to work. A lot of nurse burnout there. ER, you never really know what you're going to get. People are dying. People are fighting you. I think that's one of the things that most attracts people to ER is that you don't really know what's going to happen next. But um, it is nurses are asked to do a lot, and I think when there's right now the average nurse to patient ratio is 1 to 4 in the ER, and I think when you have one critically ill patient, it's hard to take care of three others, and you know, everyone needs an IV, everyone needs meds. So again, I think there is a lot being asked of nurses, and it's kind of an unsafe situation right now, and I think it's only getting worse financially and nurse satisfaction wise. So let's talk a little bit about burnout. So I read a few articles about burnout. There's a Texas Journal. Nurse practitioner is the author of two of these articles actually in this journal. And one, she was asking, performed a survey to about 200 nurses, and she asked, what does their burnout include? Is it emotional? Is it moral? You know, is it physical distress? What kind of stuff do they feel? And if you're in the medical field, you probably, you know, feel multiple parts of burnout, and a lot of the nurses that answered this survey did as well. So it looks like around 38% of the people that responded to her survey, they feel these symptoms weekly, sometimes two or three of these symptoms weekly. Over 50% said yes, that they even experience these symptoms every day. And in my experience, moral distress, burnout syndrome, when you're working in the ER, sometimes you can't get into patients' rooms quick enough, and you feel morally obligated to be in there, but you can't because you're taking care of another sick patient. So it's very hard. You're getting pulled in 10 different directions at once. And that's, you know, I'm not surprised that that can lead to burnout syndrome. Also, I think there's another article in the same Texas Journal written by Serena Bumpus, nurse practitioner. She actually has some numbers that are from before the pandemic, so we could probably estimate that these numbers have gotten worse. It's another survey, and it was asking it was asking if nurses feel that their facilities are doing enough to keep them around and prevent them from being burned out. And not surprising, a lot of them said they didn't. 70% of the nursing staffs that was interviewed or responded to this survey said that they are feeling burned out. 36 or 39%, only 39% of the, so quite a bit less than half, 39% of the people that volunteered for the survey said that they feel that their facilities are only slightly effective in keeping them around, keeping them from leaving, and keeping them from getting burned out. 36% went on to say that the facilities that they work for are slightly ineffective, like they're not helping at all, making it worse. 20% feel that the facilities are highly ineffective. So, I work in Arizona, and I see the same trend here in Arizona as I do in Texas, unfortunately. So, if I was to operationalize a study to kind of see how we can improve upon nursing burnout and patient ratios and financial costs for the hospitals and patient outcomes, what I would want to do is have a 3-to-1 ratio be done in a hospital for a year to see if nursing burnout would decrease, if patient outcomes would improve, and if the hospital would actually save money. And this is because I think a better ratio means better patient care. This could lead to less readmissions, less nosocomial infections, things of that nature. There will be less nurses leaving, so less turnover. And we'll go over some of the numbers and how that can save the hospital money later on. And there's another article that I read. It's in the National Nurse Journal, actually. It says that there are studies linked to the higher and higher nurse ratios get, 5-to-1, 6-to-1. Sometimes you'll see that on the medical surgical floors or other floors, unfortunately. The higher that those get, unfortunately, higher instances of accidents, patient falls, medical error or medication errors. You don't have time to do the 5 rights for every patient because you're giving sometimes 20 medications to each patient. So you're not going over the right patient, right time, right route, right medication, right dose. You know what I mean? So these higher nursing ratios are leading to higher medical errors, complication, fall injuries, pressure sores, and that can lead to higher hospital stays for patients. And we know that more hospital stays, the insurance is not going to reimburse these people, or not going to reimburse some of these hospital costs as much. Another interesting number that I found in one of these articles is that 26 billion annually is spent on hospital readmissions. 82% of hospitals that participate in the Medicare program got readmission penalties. So they're paying millions of billions for poor patient outcomes that might have been preventable by better patient ratios. So that's one thing that needs to be looked at. So again, I want to try to have a hospital with 3-to-1 patient ratios or nurse patient ratios and see if that'll improve outcomes in all factors for the hospital, for the nurses, for the patients. So I have an article here that has some very promising numbers. This article comes out of a hospital in Queensland. And I don't know where that is. I believe it's in Australia. Forgive me for my geography skills. But it was around 400,000 patients, 17,000 nurses were included in this study. 27 public hospitals. And they compared a couple years, like I want to do with my study. They knocked their ratios down, which were pretty incredible, by the way. They knocked their ratios down from higher to only 1-to-4 during the day, which I feel lucky. In America, it's 1-to-4 like max, and 1-to-7 at night. So they're having 1 nurse to 7 patients at night somehow. I don't know how a nurse can do that. But their numbers were very, very promising when they improved and lowered their ratios. So in this study, in these hospitals, year to year, and it says here that the number of patients seen didn't differ dramatically between the years that they changed the nursing ratios. So this article states that 145 fewer deaths occurred. 145. That right there, I think, should be alone a reason for us to try to improve nurse to patient ratios. Uh, Readmissions decreased, 255 fewer readmissions, 29,222 fewer hospital days were accrued versus the year before when they didn't have these nice patient ratios. So because the nurses were able to provide better care to the patients, better patient outcomes occurred. The nurses were probably happy that there was less um, that there was less stress, there less patients to have to take care of, and the hospitals are probably happy because they're paying less money on less readmissions and less hospital days. We all know that hospitals eat up a lot of the costs for readmissions and days that the patient stays longer than they were expected to. So when it comes to what sources of internal evidence I would use a lot of the same evidence that they did. Are there less hospital stays? Is there less readmission? Is there less turnover? And turnover is a big thing because it costs. I look up the cost to hire new nurses. It costs about $80,000 to train and hire a new nurse for hospitals, on top of paying them $80,000 a year. If you would have just kept that core staff person and tried to help them feel less burned out, you'd have saved yourself $80,000 per nurse. So I think that if my study, if the internal evidence that I can improve upon, if there's an improvement on patient outcomes, is there less hospital days accrued? Is there less injuries or nosocomial infections? Is there less readmissions? Does it save the hospital money? Does it keep nurses around? If those outcomes improve, then I think we have something here. If not, that's okay. So when it comes to what theoretical model I would use for this, it's called the SEM theoretical model, called the structural equation modeling. And it's kind of complex, but it explains interactions among variables. And in this one, there can be multiple variables, multiple relationships between variables. So we're trying to find the relationship between nurse to patient ratios and improved outcomes, improved hospital finances, and improved nursing satisfaction. So multiple variables can be used. There's a way to protect this by, if there are relationships that we find are weaker than the set point, or if they're greater than the P level set by the researcher, they're removed from the model. So we're not going to pay attention to that data. It probably isn't relevant, probably won't, shouldn't be presented as facts. So last but not least, when it comes to if there is anything that is ethical considerations, I don't know what is unethical about improving patient ratios, especially if we can have as positive effects as this hospital did in Queensland. I think it's ethical not to try. Okay, makes everyone happy, and we got into this business to help patients. And I think, for the most part, these numbers that in this Queensland article directly show that patients do get something out of this, and that's the most important part. I think 145 fewer deaths, that right there, I think it's ethical not to try it after seeing 145 fewer deaths. But again, lower ratios help nurses, lower readmission rates, lower hospital days accrued, those help the hospitals. So I think everybody wins here, and I think it's unethical to try. Well, thank you for listening to me today, and I hope we can improve upon this issue together and improve it for all populations in the medical field, nurses, hospital administration, and most importantly, patients. Thank you very much. Have a great day.